studies suggest that pre-reperfusion administration of IV metoprolol reduces infarct size in ST elevation myocardial infarction. And now a paper in the May 10th issue of JACC is looking at the timing of IV metoprolol in this setting. And there's an accompanying editorial comment, and I am with the co-author of that. It is Dr. Robert A. Kloner, who is an MD and PhD, who's a professor of medicine at the University of Southern California in Los Angeles, as well as the VP of Translation at Huntington Medical Research Institute. That's in Pasadena, correct?
That is correct.
And I should mention your co-author of this editorial comment is Eugene Brunwald.
Yes.
You keep great company. Can we talk a little bit about this? This actually goes
Sure.
back to kind of, as I think you phrase it, this is kind of the rejuvenation of a concept, right?
It is. So really studies that were done some 40 years or more ago in the laboratories of Dr. Braunwald, Marocco, Reimer Jennings, and I was involved in some of those studies as well, showed that beta blocker therapy given during a period of ischemia prior to reperfusion could reduce myocardial infarct size. And that concept has been around for a while, but it's only really been recently that it's been looked at where beta blockers have been combined with primary percutaneous coronary interventions to reperfuse or reopen myocardial infarcts. And
I mean, it's really Medicard, wasn't it, that kind of brought this back to the front burner?
Yes, and this is these are studies that were done by Drs. Ruiz Garcia and Ibanez and others that show that combining metoprolol with reperfusion could in fact reduce myocardial infarct size measured by current techniques such as magnetic resonance imaging.
So now this new study is taking a look at the timing of that administration.
So they looked at the time between the administration of IV metoprolol versus reperfusion and found out those patients who had longer durations of getting metoprolol prior to reperfusion had smaller infarcts and better left ventricular ejection fractions. In fact, the investigators found that for about every 10 minutes of IV metoprolol, there was a reduction of about 1.1 grams of necrosis. So the key here is the earlier the IV metoprolol is on board, the better. And it appears that it's got to be on board during the period of ischemia, and that was what they followed up with in an experimental animal model, that the longer the metoprolol was on during the duration of ischemia, the greater the reduction of infarct size was. If you simply gave metoprolol after reperfusion, it did not work. And that actually correlates with some studies that we did in experimental laboratories with Dr. Braunwald and others 40 years ago. So this concept has now come back.
So what's your take-home message from this?
My take-home message is that I think if the patient can tolerate beta blockers, IV beta blockers ought to be considered. They ought to be given as early as possible. Specifically, they ought to be given prior to reperfusion, and the longer they're on board prior to reperfusion, the greater the chances that the infarct size is going to be reduced and ejection fraction is going to be improved.
Well, this sub-analysis actually of the Medicard data, correct, is in the May 10th issue of JACC, and is the editorial comment here. So please check that out. And for CardioSource World News, I'm Executive Editor Rick McGuire.